Conspiracies Against Wellness with your host, Janelle Elgaway.
Good evening, Call Nation. A special show with Janelle Elgaway live from Washington, D.C. Take it away, Janelle.
Good evening. Welcome to Conspiracies Against Wellness. I'm your host, Janelle Elgaway. If you have a question or comment for our guest this evening, please call in at 415-915-2291 or listen and chat with me live on our YouTube channel, Conspiracies Against Wellness Livestream. Tonight, we have guest Andrea Anderson discussing how and why the opioid crisis was started and created, and the legalities, and what do intractable pain patients and doctors have rights as. Andrea, welcome to Con Nation. How are you this evening?
I'm doing very well. Thank you for having me.
We're glad to have you too. So, can you please tell me a little bit about yourself and your background?
Yes. I am currently one of the directors of an organization called the Alliance for the Treatment of Intractable Pain. I found myself a member of this community of intractable pain sufferers in 2006 when I was supposed to have a surgery called a microdiscectomy, which was a pretty minimally invasive planned surgery to remove a little piece of the herniated disc. Unfortunately, my surgeon confused me with a different patient, and instead I received a different surgery that required him to cut out the bones of my spine from level 3, lumbar 3, all the way down to the sacral 1. So about 4 levels of the back of my spine was cut out, and no support was left in place. So my back kind of collapsed, crushing all of the spinal nerves along with it, and kind of allowed me my descent into wrestling with untreatable, incurable, unbearable pain.
I'm so sorry. So I kind of want to just jump right into this because we have a lot to go over. Everybody should know that I was here this week with Dr. Klein, Lauren DeLuca, and then also joining us is Stacy Fields and Tammy Hale, Nikki Hale, and their friend Jay. And we were here to talk to our officials about the problem with not just the opioid epidemic, but that intractable pain patients are not getting being treated correctly. So I just want to understand, how did the opioid epidemic occur or start?
Well, you'll have a lot of opinions and a lot of different people who have opinions, and thoughts about that. But as part of the Affordable Care Act, an attempt to make addiction treatments more accessible, a law was passed called the Comprehensive Addictions and Reforms Act. And as part of that act, a fund of multiple hundreds of $1 million was set up to allow for the treatment of addictive behaviors or people who are suffering from addictions. And at that same time, a lot of pressure was put on the government to respond to what was perceived to be a tremendous increase in the amount of overdose deaths. So we kind of had those two events happening together. One of the big issues that's been a problem that our organization is trying to fix is that there's been little distinction made between the real cause of overdose deaths from illegal opioids or its analogs versus people on prescription, legitimate patients who have a legitimate need for these medications. So there's been a lot of media attention on overdoses without anybody truly recognizing that we're talking about two different patient populations. So that's the beginning, but it gets pretty murky as you try to sort everything out.
Right. Well, and I think, I don't think we have a really good background or understanding of what exactly happened. So who are the major players within the opioid epidemic? Like, who's
Sure.
driving it?
Right. So who's driving the opioid epidemic? Well, it's certainly been a tremendous media campaign that's been going on for a few years, largely driven by a group called Physicians for Responsible Opioid Prescribing, otherwise known as PROP. PROP is generally considered to be an anti-opioid group sponsored by addiction industry professionals, and they heavily lobbied the United States FDA originally to try to get a series of guidelines put in place to limit opioid prescribing. They were unsuccessful at that time because the FDA determined that the claims that they made against the use of opioids were unscientific and unfounded. So the members of PROP moved over to the CDC, and in conjunction with the CDC and many members of PROP and the addiction community, a series of guidelines was published in 2016 called the Centers for Disease Control Opioid Prescribing Guidelines. And that has created a tremendous issue in the community of people who need pain medication for survival.
What's their main goal? Like, if they can achieve everything they want, what are they wanting to achieve out of all this?
Well, it's an interesting, what would they say they want or what do they want might be two different issues. I can tell you what their position is. Okay. Their position professionally is that they don't want to ban all opioids. Professionally, they would state that they believe opioids are an extremely important class of medication, but they would put in this clause that says, particularly for end-of-life suffering and severe acute pain. They would say that they don't support any constraints on a physician's ability to decide to use opioids for chronic or intractable pain. However, if you ask them, do you want to stop the promotion or the use of long-term opioids for non-cancer pain, they would say yes. So that would be their professional stance. How they come across in the media has been a little bit more, a little less refined. One of their main spokespeople, Dr. Andrew Kolodny, has been a very polarizing figure in the media, making very brash statements such as, there's no difference between an opioid and heroin pills, very abrasive and not always appreciating the nuances of using opioids properly in a pain management session, means, as opposed to illegal use of illicit opioids that can be found on the street, which do tend to cause overdose deaths for many reasons we can talk about if you like.
Well, what kind of doctor is he?
He is a psychiatrist, not a clinical pain management physician, and most of the members of PROP are not pain management physicians. Most are addiction-related professionals. That was one of the major criticisms of the CDC's panel of core experts that they used to design these guidelines. They used mostly addiction professionals. Many people from PROP were involved in the creation of the guidelines, but notably absent from the core experts who designed the guidelines were pain management physicians, pain advocates, or even pain patients. Their input was not welcomed, and most of the guidelines were written in secrecy, which kind of defied the Open Meetings Act, which they were caught on by the Washington Legal Foundation and forced to reveal. But by that time, the guidelines had been written, and they are relatively seen as anti-opioid and have caused tremendous difficulties for patients who have been stably and responsibly using them for years.
So a lot of doctors, it seems, are treating these guidelines as if they are law. Why are they treating it as a law? And
that is
what is going
excellent.
on by treating it?
Well, that is an excellent question, because if you told the CDC that these guidelines are hurting patients who need opioid pain medication for the treatment of intractable, incurable, unbearable pain, they would respond but they're only voluntary guidelines. Nobody has to follow them because this wasn't a legislative process. This wasn't an open meeting where many people were consulted to come to a consensus. This was a particular group of people with a particular agenda. So they declared that they really didn't mean to do any harm because they're just voluntary guidelines. But a legal interpretation of the effect of the opioid prescribing guidelines essentially would state that by going ahead and taking a position on how many milligrams of opioid medication can be safely prescribed, and the CDC guidelines would say normally 50 milligrams a day is the general threshold, but over 90 morphine equivalents, you're really in dangerous territory. From a legal point of view, that becomes what's considered the standard of care. And the standard of care is what's used to consider malpractice, for example, and it's usually defined by what would a reasonably prudent practitioner in the same or similar circumstances do or prescribe, with this patient. And what would the effect of the CDC guidelines would be this. If a malpractice case was brought against a physician who had prescribed more milligrams than the higher amounts, the malpractice attorney could easily point to the CDC guidelines and say, physician, could you please read the line here that says 50 milligrams is maximum and no more than 90? Could you please explain then why you felt it was safe to prescribe 120 milligrams? And pretty much the doctor would have no standing. So the guidelines, while meant to be voluntary and say that they allow for clinical decision-making in theory, in practice what we're finding is most states and most doctors and most hospitals are implementing the 50 milligram threshold completely. For example, in Colorado, the initiative is no more than 50 milligrams to anybody. Washington State is proposing a kind of a 50-90 split. But it does seem that most states and most courts will interpret the CDC guidelines as a standard of care when it comes to legal terminology.
Did I hear correctly that they're actually going to try to also make it law that no opioids could be prescribed at all except for cancer patients, or was I wrong on that?
I don't think anybody has gone that far. The CDC guidelines said that they weren't going to necessarily apply to cancer treatment, acute pain, palliative care, or hospice end-of-life care. These were meant to be, they would say, prescribing guidelines for a general practitioner, usually in a setting where pain management physicians are not available. Currently, there are 4 pain management physicians for every 100,000 pain management patients. So clearly not enough specialists to go around. So the maintenance of many people with painful conditions falls to general practitioners. And those were supposedly the only people who were meant to use these guidelines as a framework for clinical decision-making. But they have taken on a life of their own and become regulatory in virtually every state where legislation has been proposed.
So, when I was meeting congressmen and senators yesterday, this came up, and they said, well, these are just guidelines. They're not the law. And I said, but they are treating them like law. And, there's so many doctors that are not prescribing for patients anymore. They're just dropping their patients, or they're weaning them down, or they're doing this, they won't go over the guidelines. And
right.
They said, well, why aren't doctors coming together then? Like, why? Because all they have to say is no. And I said, well, because doctors are getting looked at by the DEA then. Some have been raided. Some have just lost their license. And they're like, well, they had to do something if they lost their license. How can, if somebody wants to go to their lawmakers, how can you get this across? Because I got frustrated, and I've never done that before. I didn't know how to respond, Do you have any advice on that?
Right. Well, I think it's a twofold answer to your question. Number one, why aren't the doctors' organizations speaking out more is, I think, your first question. And the second one is, how could we speak to our legislators, about this issue? let me answer the first part first. One of the major reasons that physicians are not speaking out is really simply a matter of time and the concept of exposure to risk. Our doctors are put in a really difficult situation right now when they reach out to prescribe an opioid. They may know that it's clinically appropriate to do so, but they're actually being put in a position of whether or not they would be putting themselves at risk if they did so. For example, if you had a patient on long-term opioid management who might need an increase because they had become tolerant at a certain level, instead of putting the patient's well-being up first, the doctor now has to consider whether or not he puts his practice at risk by helping that patient with a higher dose. And because their exposure to risk is one of the most difficult parts of the profession, they'll also be getting pressure from their malpractice carriers or their hospital boards or the groups that own them to stay well within and under the CDC guidelines to make sure that they have no risk exposure should a patient accidentally or even intentionally overdose. So one of the main things is that they just need to know where are the boundaries for them. And most physicians are willing to stay within the boundaries if it protects their livelihood and their practice. You mentioned the DEA raids and things like that. That is a very true thing that's happening, is that the DEA is getting warrants to raid the practices of physicians who prescribe opioid pain medications, especially if they are over what the CDC thresholds might have recommended. So that's what they call in legal profession the chilling effect, which is usually designed as the inability to express legal rights due to a vague and threatening loss of, your practice or your financial support. So while doctors clinically have the right to prescribe whatever level of opioids they feel is proper, the chilling effect means that if they do so, they're putting their practices and themselves at risk. With regard to legislators, I think we need to explain to them that our doctors are just trying to conform to these guidelines, and it's the guidelines that are flawed and how they're being applied, and that we need legislative help to either get the guidelines completely revoked or get them revised by allowing pain management and other practitioners in treating pain, like physicians' assistants and nurse practitioners, allow them to participate in the process of creating these guidelines would be a great help.
And isn't there a board right now currently that has been able to be there to, or do they do the CDC guidelines? I was just wondering who is on this board, and are we being is it balanced? Are we being represented?
Are you talking, let me just clarify, are you talking about the core experts who wrote the CDC guidelines? Okay, so we would not consider that to be a balanced group. There were three main authors of the CDC guidelines. One had practiced in emergency medicine, but now was focusing on child safety seat laws and anti-obesity campaigns. Another was focused on another issue related to children, and another was an academic, a professor. Then there were 19 other specialists or practitioners who participated in what was called the core experts group, and they were the ones that were consulted during the writing process. And in that core expert group, there was not one pain management physician represented. We had addiction specialists, we had, general internists, but not a single specialist in the terms of treating pain and the necessary dosages of opioid prescribing for that population. So that panel is not regarded in any way as being balanced, and that's one of the main complaints about the CDC guidelines, is that they were biased.
Why don't they have anybody on there representing everyone?
Well, it seems like a good question, right? I mean, it seems logical that if you were going to write guidelines that govern the prescribing of opioids, that you would include pain management physicians, being that is their specialty. But the influence of the members of PROP, relationships that were had with members of the CDC, somehow gained them great influence and allowed them to do this work in secret and then publish it to grave effect. As a matter of fact, Congress actually enforced the CDC guidelines for the Veterans Administration before they were even published, which has had a tremendous effect and a negative impact on our veterans who clearly went away to serve their country and got injured and now have come back to be tortured by us because we're limiting their ability to manage their pain. So it's been quite a trauma.
What's going on with our veterans? They're not receiving any care at all now?
Well, that has been the shift. As soon as the CDC guidelines were written, Congress forced the Veterans Administration to accept them, like I said, even before they were officially published. But since that time, this seems to have taken an almost absurd level of what I would call a hysterical approach. It's as if every opioid in every situation is bad, and most veterans are being tapered either forcefully or not so forcefully, but tapered down at least under the CDC guidelines, and many, if not most, completely removed from their only source of pain, analgesia. It's been a grave danger.
Yeah.
I'm sorry, go ahead.
No, that's okay. Can a doctor be held liable for prescribing outside the CDC guidelines? Because it seems like they say one thing, but they're doing another thing. So can it happen?
That's exactly right. Yes. I mean, so the question is, can a prescriber be held legally liable if they prescribe a dose that's outside the CDC guidelines? For example, like the DEA might, do a raid or search a physician's practice if you prescribe more than the recommended 90 morphine milligram equivalent. The question is, how much legal weight would the guidelines carry? And the answer is that a state licensing board or a federal court could easily use the CDC guidelines to be the accepted standard through the testimony of medical experts. And if a provider prescribed more than 90 milligrams of morphine equivalency a day and was not complying with an additional state guideline, because states are also implementing their own guidelines, often even more stringent than the CDC, so a physician has to be compliant both at the state level and at the federal level. This provider could absolutely be held legally accountable. Even though the CDC guidelines don't say that a physician can't prescribe over 90 milligrams, several states have adopted rules that say absolutely not. Maine, for example, imposed a 100 morphine milligram equivalency limit on opioid prescriptions, with exceptions for terminal cancer and palliative care. So pretty much risk management-wise, providers or physicians are being told to look at the 90 milligram per day dosage as a marker of like serious pause, don't go over here. But if their state licensing board uses a lower one, then they have to stop at that line. So yes, they absolutely can have the force of law and are using it to commit raids and things on pain management physicians' offices, seizing records and penalizing the physicians for those decisions.
Okay, you mentioned cancer. Is cancer pain the same, or do they ever find out if it's the same or not the same as intractable pain patients or, chronic pain patients? Do they know?
That's a great question. Many people have made the statement that, the exception to these laws should be, like I said, cancer pain, palliative care, and hospice care. So the question is cancer pain different than pain from failed back surgeries or pain from regional sympathetic, nerve disorders or multiple sclerosis or any of the other 200 diseases that have, severe pain as a symptom? And as far as we know, the FDA denied that statement when PROP attempted to push through an idea that there was a difference between cancer pain and non-cancer pain. The FDA rejected that as a statement that had no supporting evidence. So as far as the guidelines are concerned, there should not be a distinction between cancer patients and non-cancer patients. And if I may bring up one more issue, cancer patients often do become, in remission, but they still can be left with severe pain syndromes from lymphedema or other casualties of the treatment of cancer. So then the question is, how are those patients to be treated? They had cancer, they don't anymore, but they're still in pain from the therapy or the lasting effects of the cancer itself. So how are they entitled to treatment now? Because they had cancer as its origin? So that's another area that's vague and undefined and problematic. And usually physicians are choosing not to treat it because it's safer for them not to treat it than it is to take the risk and treat it appropriately. And really, that is for the first time essentially pitting patients against their own doctors, where a physician has to decide what's in the best interest for the patient may not be in the interest of the physician, and then puts them in an ethical quandary that is never before happened. So it's a really challenging situation for both patients and clinicians.
We have a question from YouTube Live. Shelly Bean says, is there some reason why doctors aren't banding together in numbers and pushing back? And can the DEA go after a large group?
Okay, so that's two questions. Is there some reason doctors aren't banding together? I can tell you for sure that every pain management group sent very strongly worded language to the CDC in opposition to the guidelines. Included in that would be the American Cancer Society, who also wrote in opposition to the guidelines. But as I said, they were not allowed to be involved in the writing of the guidelines. So essentially, their protests are noted, but haven't had great effect. One good thing that we're hoping for significant change is the new task force, sponsored by the Health and Human Services Division, which is a new task force designed to look at opioid policies. And this particular panel does seem to be inviting pain management experts, physicians and internists who treat pain medicine, pain patients, and even advocates for people with intractable pain. So we do have hope that the new Health and Human Services opioid task force will do a better job and will hopefully clarify many of the issues where the CDC guidelines have caused more harm than they've helped. And then I think the second question was about large groups.
Can the DEA
right?
go after a large group? Yes.
Well, the DEA would probably not go after a large group unless the entire group, practiced in such a way that each member of the group would be perceived as in violation of whatever standard it is that they want to apply. As again, the CDC guidelines were not meant to be law, but if they choose to interpret them as the threshold and every member of a practice was prescribing over them, then yes, the DEA could rate a practice. But in general, they take action against individual prescribers because many times in a practice, not every doctor is even licensed to prescribe controlled substances. So usually it would be a physician one-on-one with the DEA.
We're going to take a quick break and hear a word from our sponsor, and we'll be right back.
Thank you.
Coming soon, Caw 360 Network. At the same place you get the Caw Show now, you'll be able to get great new shows like Save Our Children, Enhancing Your World, Wake Sheep, and of course, the Caw Show, with more to come. Caw 360 Network will educate, enlighten, and inform you. And you won't have to hunt all over the internet because it will be all right there on the new Caw 360 Network. Think of it as your one-stop for your daily dose of truth. So stay tuned. Great things are happening, and Caw 360 Network will be leading the way. And we're back with Janelle Elgoway, live from Washington, D.C.
Welcome back, Caw Nation. Tonight we are here with Andrea Anderson talking about the opioid issue. So we were talking about intractable pain. What is intractable pain exactly?
That's a really excellent question. There's a very specific condition that the term intractable pain covers, and it is slightly different from chronic pain. And let me read you the definition as written by one of the pioneers in the treatment of intractable pain, Dr. Forrest Tennant. And he defined intractable pain in the following way: as a severe, constant pain that is not curable by any known means, that results in a bed or housebound state if not adequately treated. And that would be the basic definition of intractable pain. So a severe, constant pain that is not curable, that results in a bed or housebound state if not adequately treated. And at the moment, opioid medications are the only true treatment that we have to manage pain.
What kind of health issues fall under intractable pain patient?
Right, and that's a really important distinction because, many people have pain, a bum knee or a sore back or a muscle strain. Intractable pain is considered, a more severe form of pain in that it causes measurable adverse biological effects. And by that I mean the body's cardiovascular system, their hormonal system, your immune system, and neurological systems are all now functioning in a different and more dysfunctional way. And intractable pain is actually measurable in several ways. Here's a few ways, so this isn't the only ways, but usually some easy signs to know that somebody's in severe intractable pain would be consistent elevated blood pressure, a very high pulse rate, abnormal immune system markers in the blood, reduced or elevated hormone levels, and inflammatory markers in the blood. So it's an interesting question about, can you tell if somebody's truly in pain? And the answer is absolutely. While some people maybe have lied about being in pain in order to obtain, medications illicitly, intractable pain is absolutely measurable and is verifiable on its own standards and doesn't require, an unconscious patient could be defined as having intractable pain just by the numbers of their cardiovascular system and blood tests and results from those.
People that are pushing the opioid epidemic, what are they wanting intractable pain patients to replace opioids with if we can't treat it that way? What are we supposed to do?
That is an excellent question and one that many people are very concerned about. The question is, what can these patients do if their access to opioids is gone? And the answer to that is there's not a whole lot. As a matter of fact, I received some recommendations from an anti-opioid group suggesting the following therapies. One was called grounding, in which patients were advised to somehow interact with soil and dirt as a method of bring your blood pressure and heart rate down. We had recommendations for shiatsu pressure by, using your thumb to push pressure points, the use of essential oils, massage, like CDs that have, C sounds or things like that. Most things that people with intractable pain have already tried innumerable times and found to be completely ineffective. But there is absolutely nothing right now that can manage pain like an opioid, because if there was, most people would use them. It would be easy and would have no conflict. But the issue is they are the only effective medications we have to manage intractable pain. And Dr. Tennant has written that at some point, intractable pain becomes a disease in and of itself, meaning that you may never be able to fix the underlying reason for the pain, but pain now is your disease and it will kill you if it's not treated, because the constant cardiovascular issues of high blood pressure and high pulse rate and high heart rates and poor immune systems and inflammatory markers make a patient in untreated intractable pain very vulnerable to heart attacks and strokes and other immune system assaults. So at some point, it really becomes a disease that just needs treatment in the same way that diabetes or high blood pressure or, any other treatment, any other illness would need. And that's what's made the CDC guidelines so difficult for so many pain patients, is that being forcibly removed from the only medication that can save their lives has left them with terrible options. I think most intractable pain patients who've lost access to opioids would say they have no good options. Most feel that turning to illicit or illegal drugs is a risk that they're not willing to take, but neither is the option of living in unbearable, untreated pain. which brings many people to the only choice left, which is suicide. And we've lost hundreds of people, if not more, already due to the effects of the CDC guidelines on removing people's access to pain management, which in a way has become an epidemic of itself. So in trying to treat an epidemic, they're actually creating a whole nother epidemic of innocent patients who are now losing their lives either from stroke, heart attack, or from suicide. So that may not have been the intention, but it certainly has been a grave harm that needs addressing.
When you say they, so that's the side that's pushing this agenda, what are they wanting to replace opioids with, or what are they expecting everybody to go to?
Well, one of the most prolific and one of the most influential members of the anti-opioid movement, if you would say, would be Dr. Jane Ballantyne at the University of Washington. And she recently published a paper in the New England Journal of Medicine titled Intensity of Pain, the Wrong Metric, Strategies for Managing Pain, something like that. And in it, she concluded that they should no longer use a patient's reported or obvious levels of pain as an indication of treatment, but instead offer support, encouragement, and hope, and encourage the patient towards acceptance. So that's about what they've offered, is acceptance of the fact that you're in unbearable pain.
So they're not saying, like, we're going to give you something else, a different drug. They're not telling us to do anything else. It's just accept?
Well, generally, yes. I mean, there are some other medications that people use to try to treat pain that are not opioids. For example, like gabapentin and Lyrica, which would be anti-seizure medications. Some people might be given antidepressants. Those are different classes of drugs that are not analgesic in the sense they're really not designed for pain management. But, for example, in the anti-seizure medications, they're designed to slow down nerve transmission. So the thinking is that maybe if you use an anti-seizure medication, pain signals won't be transmitted as quickly. There are also some devices like spinal cord stimulators that can, be used in severe cases to scramble, let's say, the electrical impulses of pain to the brain. Most pain management doctors are moving to what we would call interventional pain practices, where they will use epidural steroid injections, radiofrequency ablations, lysis of adhesions, and what we call interventional things that involve, injecting the body or altering the body or burning nerves that are causing pain. But in terms of medications, there is no alternative to opioids that we know of as of now. And we know that morphine has been used for thousands of years for pain management. And so far, we haven't found another substance that treats pain in the same way.
What about, I've been hearing about Suboxone. What's going on with that? Is that a form of that they want to use?
Oh, Suboxone is an interesting medication. It was originally designed to be a medication used to help people with addictions to heroin or other illicit or even opioid addictions. It contains a medication called buprenorphine, which is actually an opioid in and of itself, but it's combined with a substance that minimizes the withdrawal aspects of an opioid. So some people are trying to use Suboxone now as a pain management tool because it's easier to get Suboxone than it is to get an opioid for pain management. Suboxone has some pretty serious side effects of its own, and as far as I know, reports are just not consistent as to whether or not it's effective. I think for many pain management patients who've been abandoned by their physicians or forcefully removed from their opioids, many will try to get Suboxone because it's at least something that has a little something that could maybe help. But many are actually turned away from Suboxone clinics because they're not true addicts. They have to show that they are a person who suffers from an addiction, and if they can't qualify, then they can't even get access to Suboxone. So it's not simple for pain patients to have access to Suboxone, and it's not really concluded about whether or not it actually treats pain. but it can help people not go through withdrawal if they are removed from opioids forcefully.
Can you talk about the difference between addiction and dependence?
Yes, that's a wonderful and excellent question. Everybody has their own sort of way of expressing it, but the way I like to talk about it is this. Dependence is a completely predictable, completely natural situation that occurs when somebody's system is used to receiving a certain substance on a regular basis and becomes accustomed to it. And probably the best example of that would just be coffee. Many people start out, with a cup or two of coffee a day, but if they stopped abruptly, they would go through what we call caffeine withdrawal, which is a predictable outcome, usually headaches and fatigue and crankiness for a few days. And that's because their body was dependent on caffeine on a regular basis. And if you remove it, then the body reacts to the lack of the substance. But you will reset, as soon as the withdrawal is finished and be okay. Addiction is, I like to describe it as a person who's compelled to use a substance to their harm. People with addictions are usually not using medications to improve their lives. For example, a pain patient might use an opioid to be able to keep a job, to be able to take care of their family, to be a good companion to their spouse or a good parent to their children. And in their cases, opioids restore function and allow them to remain productive, involved citizens. Where somebody with an addiction might be driven to use a substance, and even if they lose all of those things, jobs, families, homes, cars, finances, etc., the desire for the substance is more compelling than even any reason to stop. So dependence is a physiological fact. Addiction is a set of, well, nobody really knows exactly if it's behaviors or brain chemistry, but usually it's defined by it's harmful to the person who's addicted to that substance.
Okay, so supposedly they've dropped like big time on prescribing opioids. I did see something recently about that heroin actually is the number one drug right now on the streets. People are going to heroin and they're not even trying an opioid first, whereas, that was kind of the stereotype before. Was it a stereotype or was it true that they'd try it first? But why isn't any attention coming towards the heroin and stuff like that? Like, why are they blaming it on this?
Well, that is an excellent question. So there's a narrative that goes around that says an innocent person received some Tylenol 3s or, let's say, Norco, Tylenol plus a form of codeine, for a root canal or a routine surgery. And somehow in that 10 days of exposure or 7 days, or that somehow either they became so craving of that substance that they ended up doing heroin and dying on the street or becoming heroin addicts. The research does not bear that statistic out at all. As a matter of fact, studies done by Fishbane and his companions, and a Cochrane review done in 2010, I believe, showed that less than 3% of people who even used opioid medications ever developed any sort of opioid use disorder or abused their medications. But you're absolutely right in that in all this attention on removing access to prescription opioids, what has actually happened now is we now have a very full-blown heroin epidemic, because heroin has now surpassed even prescription opioids as what is called the initiating opioid of abuse. In an article published in Addictive Behavior in November of this year, the authors state that the recent growth in access to heroin and the inability for people to get any access to opioids has sharply increased the use of heroin, has grown at an alarming rate. And because that people who start using drugs are now starting with heroin, overdoses are very, very likely because they're not ramping up to a harder drug. They are just, it's so easy to get. It's a very permissive drug. Lots of people can get it. It's inexpensive, and so it has now surpassed even, this idea of a prescription drug that they got is no longer even true. The other issue regarding this overdose situation is that there are certain medications that have now been entered into the United States, forms of illicit fentanyl and fentanyl analogs, such as carfentanil, which are highly, highly dangerous substances that can be bought online through China. As a matter of fact, one Chinese website had carfentanil right next to the chicken nuggets. You could just click a button and have some mailed right to your house. And the heroin supply is often being cut with fentanyl and its analogs, and unsuspecting users who have no idea that these very dangerous drugs, carfentanil is actually an elephant tranquilizer. So you can imagine if a person who thinks they're doing a certain amount of heroin is actually introducing a large, an amount of carfentanil, how heroin overdoses are now the number one cause of overdose deaths, by more than 90%, according to the CDC, for the last quarter of 2017.
Shelley Beans asked, what was the name of the publication again? I think she was talking about when you were talking about the heroin numbers. And
Sure, okay. Yes, you can find that study in the Journal of Addictive Behavior, November of 2017. And the author information there would be T.J. Cicero, Cicero, and the other authors' last names are Ellis and Casper with a K. And I do think that's a very important study for us to be paying attention to. So all this limiting of opioid prescriptions has now essentially created an even greater heroin epidemic. So it seems like if you wanted to write a playbook for how to create a heroin epidemic, this is how you would do it.
Fearless Taurus also asks, what is pseudo-addiction?
Pseudo-addiction. Okay, so that is a term that is used to describe a behavior that, so if a person is a pain patient, but they are not stable or undertreated, that they might go to their physicians begging for more medication out of a desperation or a terror or anxiety or just being overwhelmed with pain that makes them present in such a way that the doctor thinks this person just wants more drugs. So they might mistakenly attribute those behaviors to addiction when really a pseudo-addiction is exactly that. It's false addiction. It's not about addiction. It's about a person whose pain is undertreated. And instead of cutting that person off further, what would be clinically appropriate would be to treat them according to their pain and as it's needed. And before the CDC guidelines that were in place, I'd like to just add that there was a very, very simple solution to treating people's pain, which could be described as titrating to effect. Meaning, if somebody was in great pain, you might start them with a mild analgesic like Tylenol or Motrin or aspirin. If that's ineffective, you might move to the next level like Norco or Tramadol. And if that's ineffective, you might move to morphine, a small dose of morphine. And if that's ineffective, you move to the strongest types of analgesia, legal fentanyl, dilaudid, things like that. And the idea of titrating to effect meant give the person enough that they get relief and then stop. And that has been how pain was treated around the world. The World Health Organization calls it the pain ladder. And it seems like a pretty logical approach to treating pain. But now we have these arbitrary guidelines in place. And if you think about it, a 50 milligram dose of an opioid might do one thing to a 100-pound woman, but might be something completely different to a 100 and 250-pound Marine who's just lost 3 limbs in an IED explosion. So the idea that somehow we can have one number that will treat all people effectively, it seems very illogical that this has even gone as far as it has.
Right. What do we need in our tool bag to basically, when we go talk to doctors, to discuss with them. Like, say if a doctor's trying to cut us down or take us down, or if we want to go into our legislators, like, what is important points that we all should learn about, or that you could share with us, so we can be better equipped when we're trying to fight this individually?
Right. Well, let me just share some resources. First of all, colleagues within our organization, again, if I may, it's the Alliance for the Treatment of Intractable Pain. You can find us on Facebook at our initials, ATIP, and then USA is our Facebook name. And if you are in need of some help or resources, our colleagues have written some very compelling papers that you can bring to your doctor's offices and to your legislators. We also have tools like point papers and how to approach your legislator, how to find a legislator, how to talk with one. So we can certainly help anybody who would like to do this. And may I say that it is the right time to do that. Pain patients right now are losing access to life-saving medication due to some arbitrary guidelines designed by people who are not even involved in the treatment of pain. And if you don't want these to be your state laws, if you're in one of the states that hasn't passed them already, the time to act is now, and to go face-to-face with your legislators, because most of them have only heard what everybody else has heard on the news, that there's an opioid epidemic. But most don't understand that it's really two different patient populations. One is pain patients for whom opioids are life-saving, and another population for whom any type of opioid, including illicit or illegal ones, is detrimental. So we should not be sacrificing the patients who are in need of pain medication in order to treat those with addiction. Both patient populations deserve treatment to save their lives. And I think if you will go just explain even that basic fact first, it will be eye-opening for your legislators or state boards of health. And then secondly, we have many studies and resources developed that can help you educate them as to why the CDC guidelines need revising, or why, as a physician, they don't have to necessarily conform to those guidelines. But may I also add that our physicians are in a very difficult position. As I've mentioned, for the first time ever, they're in conflict with treating their patients. If they have a patient who requires more than 90 milligrams of a morphine equivalent a day, and as an aside, the idea of a morphine equivalent is a false notion anyway, but that's a different topic. For them to decide to go over that to treat their patient, like I said, they're now risking DEA or state board regulatory actions that could strip them of their practice and potentially their license. So what we really need to do is help physicians get protection to let them know that it's safe and acceptable to prescribe opioids as according to the patient's needs. And we need to have some more clear laws to define the physician's role and hopefully get the government out of your doctor's office.
Somebody's asking, Shelly Beans is asking, is there a website? She's not on Facebook for ATIP.
At the moment, our website is under construction, but if she can reach you after the show on your YouTube channel, I'd be happy to give her an email address that she can write to us, and we can help her get the information she needs.
Okay. Kilis Taurus asks, are doctors willing to stand up with us and literally go to Congress with us? I know a handful that have.
We have some wonderful and brave physicians who have stood up for the needs of pain patients, even to their own detriment. Dr. Lynn Webster, Dr. Forrest Tennant, Dr. Thomas Klein, Dr. Stephen Cortez, Dr. Mark Ibsen. We have some heroes to all of us, and that is certainly not a limited list. I could go on for a long time. But those are doctors who understand the need of appropriate analgesia for patients in intractable pain and who've dedicated their lives to relieving pain. So we do have doctors that are standing up for us and doing an incredible job doing it. We just need to support them. And really this is about numbers. Most representatives that we've spoken with literally had no idea that pain patients were being affected by policies designed to curb addiction. So there's a lot of education that needs to happen, and it needs to happen quickly.
Yes, in fact, Dr. Klein went with us Tuesday, and it was awesome having him there. The other thing is, you're right, because when we were there, two of the meetings that we had, they didn't know so much of the information at all. They said nobody's knocking on our door. Nobody is telling us. We get like professionals and stuff that come in here, but we don't have, the normal everyday person that's going through that. And they really liked that we were there, and they could put a face to what is going on. So
yes, it's really important that you do go to the best of your abilities on a face-to-face break. And if I may say, the Christmas holidays is a time when your legislators are home. Your federal legislators are in their home office. So for the next 6 weeks, or as soon as Congress, is out of session, this is a time for you to make an appointment and go in. And usually you will speak with a staffer first and explain what your concerns are. But it's very important that you establish the fact that a pain patient, that you develop empathy, that they understand that, like in my situation, I was the victim of a wrong person surgery, and that has left me with unbearable pain. Everybody understands the need for pain relief. As a matter of fact, there was a study published in Vox magazine, or online magazine this week, that asked physicians what services would they want in end-of-life situations. And the only thing that this group of physicians said that they would want in terms of treatment was pain relief and adequate analgesia. They didn't want antibiotics. They didn't want any of the other things at end of life except for pain management. Everybody understands what it's like to suffer, and everybody understands what it's like to have relief from suffering. And it seems that in our country, we're going backwards in terms of relieving the suffering of our citizens. So while we treat addiction with the best tools that we have to save as many people as we can, we shouldn't be sacrificing the pain patients on the altar of that need as well.
I think we have a caller. Brian, do you want to say it? Because I can't see it.
Hey, this is Trillis Toys. Sorry, guys. I'm sick. I apologize. I actually have a question, and it kind of falls on to the whole, treating the chronic pain patient or the intractable patient. I'm not sure where everyone else is located, but, actually with our primary care provider, I learned something that was very interesting. They are not allowed to treat chronic patients whatsoever with any types of pain medicine. As far as it being opioid, I had a problem where in my situation for 8 years, my PCP never did a test, anything like that. And I learned 8 years later, thanks to a wonderful doctor, that I had EDS. I had to go to my regular PCP because I was just having a foot issue, what I thought, and he diagnosed me with plantar fasciitis. He looked me in the eye, and you literally see him get so upset. He's like, I can't treat you. I can't do anything as far as providing you any pain treatment. And I kind of just started to talk to him. That was before I was getting any pain medication whatsoever. And I said, well, why is that? Because I kind of took it personally. I was like, is it me? At this point, when you've kind of been through the runaround, especially for me, it was like 8 years, I felt like, okay, that's it. They're against me. I really thought it was. And he told me that Carolina's healthcare system, which is who he works for, told him that no longer can any primary care provider provide any opioid medication for a chronic pain patient having a chronic issue. So even though he diagnosed me with a chronic issue, he couldn't treat me. So that's kind of like where I kind of wonder where things have changed. I'm very grateful for doctors such as Klein. Like, I love Dr. Klein. I do talk to him a lot on Twitter, and I'm very, Tennant's my hero, Laird, all of them. But it kind of makes me wonder, at what point do they I want to help them. I'm one of those, I'm very, loud. I'm very accurate. I try to get all the information. I try to help all I can. But what can we do to help them? Because here they are working for the healthcare provider. They're out of school, paying off their loans. They've got their quota to meet, so to speak. What can we do? Because before, they used to treat us just fine.
Right.
I have a quick question. Wait, before you answer that, can I ask? I just like to ask something, because I'm from North Carolina, too.
Yeah.
And I get prescribed opioids, so I was just wondering what kind of chronic pain issue do you have, if you don't mind saying it, or
no. For this particular situation, it was plantar fasciitis, but I've actually been diagnosed with Ehlers-Danlos syndrome, and at the time he knew I had 2 herniated discs, my C5, C6, my C2 slip disc, and I also had borderline cord impingement with spinal enthesiopathy and degenerative disc disease. I received every medication but an opioid.
Okay, may I take a stab at this?
Go for it.
Different states are creating new state-level laws that sometimes are more strict than the CDC's. I'm not sure that in North Carolina that there's a law that prevents physicians from prescribing controlled substances, but what I have found in my state is that to prescribe controlled substances, you have to have a DEA license. That's an additional fee and requires additional standards. And many general practitioners or family practitioners or internists have chosen not to be licensed by the DEA just so that they don't have the legal authority to write prescriptions, but not so much because they have a state law against it, but because they've chosen not to be licensed in that form of practice and instead would prefer to send all pain patients to pain management, just as I've said, because it's a risk to their practice to start prescribing opioids. And they may be pressured by the group that owns them or by their malpractice carriers or by insurers. And sometimes many doctors are just concluding it's not worth the risk to them to potentially treat intractable or incurable pain centers, or even a temporary one like plantar fasciitis, which can be excruciating, but isn't necessarily like a lifetime affliction, which is essentially creating a vacuum of care. I mean, we have so many people that need pain analgesia in order to function, but most primary care physicians are not willing to do it anymore. But I don't think there's a law in North Carolina that prevents it specifically.
Let me ask you, are there any current laws to protect doctors or chronic pain patients or intractable pain patients?
Oh, that's one. Yes, I wanted to remember to say that. Yes, 8 states have passed the intractable pain patient protection laws.
Okay.
And one really good example, I believe, is the Texas intractable pain patients law. It is a legislatively decided, document that protects both physicians and patients themselves. And another great idea for contacting your legislators is to bring, for example, it's called the Texas Intractable Pain Treatment Act and Chronic Pain. Texas Intractable Pain Treatment Act and Chronic Pain, and I can send a link to you for you to put up on your show if you'd like as a sample document. This provides protections for both the physician and the patient from over-regulatory actions and makes sure that in the treatment of or in the prosecuting of people who may be dealing illicitly with opioids or prescription opioids, that legitimate physicians and patients not be disrupted in their treatment plans. And I know that there are only 8 states that have these laws. Many more don't, and many are getting much stricter laws in place, like Maine, Washington State, Colorado, Mississippi, are some that I know right now that are affected by new laws, basically based on the CDC guidelines, but even more strict than even they were. So this is another great thing to bring to your legislators, to say, look, other states have protections. Can you help carve out protections for us from these negative, maybe unforeseen impact of the CDC guidelines?
Are there any laws that are trying to be passed to take away all these rights that are currently in the pipeline or just waiting?
As far as I know, not in the federal system, but absolutely at the state level. What we're seeing is that state boards of health are often being tasked with either forming committees or basically trying to adapt the CDC guidelines and come up with a state policy. For example, Colorado's committee recently presented what they thought was a finished document, and their limits were no more than 50 morphine equivalents a day, period. They weren't even willing to go up to the 90 milligrams that the CDC said was essentially the upper threshold. They also were trying to limit the access to opioids to 90 days for chronic pain users, 7 days for acute pain, and require proof of a 30% increase in function monthly in order to be allowed to continue on your medication, which shows a real lack of understanding, because sometimes relieving pain is all that we can do, and it would be hard to judge what exactly a change in function would be for somebody who is missing 3 limbs. Maybe just relieving their pain is enough, but they're putting some really tough guidelines in place. So everybody in Colorado, you need to get on that.
Pharmacies and health insurance companies are now getting involved in this as well. Can you tell us what's occurring exactly with them?
Well, pharmacies, okay, so let's talk about CVS if we can for a moment.
Sure.
CVS was caught actually being the group that was diverting legitimate opioids by their pharmacists and pharmacy staff for creating fake DEA numbers, fake patient profiles, and using legitimate medication that had been delivered and selling it illicitly on the street. And that's what they refer to as diversion. And there are several places diversion happens, often in theft between the opioid manufacturers and the delivery to the pharmacies, from pharmacies themselves. And apparently in the case of CVS, over, I think, a 10-state period, their staff themselves were actually the ones who were flooding these small towns with illicit opioids. So, again, the narrative that, your grandmother who had hip surgery and got 14 tablets is fueling this opioid epidemic is clearly not the truth. But it is true that certain people who have access, either through theft or, faking names and things, were actually diverting legal opioids into illegal means. So as soon as CVS was caught doing that, the next day they staged their new commitment to, prohibiting opioid abuse. And they came up with some very stringent rules limiting patients' access. And in some cases, different pharmacy chains and different pharmacies have different rules, but some of the things that we're seeing are giving a pharmacist the right to refuse to fill a pain prescription for whatever reason they feel is appropriate. Some people feel like they have to hide their tattoos. Some people feel like they need to hide who they are, because a pharmacist could arbitrarily say, I don't think you're that you're not trustworthy or worthy of this medication. Other pharmacy chains are limiting the supply to 90 tablets no matter what the physician has written. If a physician wrote for 120 tablets, the pharmacy can go ahead and just reduce it just arbitrarily because they don't feel like they should do that. And CVS is leading the pack, which is, to me, a pretty transparent PR campaign after they got caught, being the agents of diversions themselves. But essentially, it's like they're deputizing the pharmacists to become DEA agents. And I know many physicians really resent having to fight with pharmacists to fill the prescriptions as they wrote them. Because pharmacists clearly are not receiving the same training that physicians are trained, but somehow now we have a secondary police force, if you will, deciding who is worthy of these medications and who is not. And then insurers certainly are stepping in. We know Blue Cross Blue Shield was involved with some meetings regarding this. So we know that insurers are also have some involvement, although they have refused to release the content of their meetings with our legislators. So nobody knows exactly what they discussed, but we do know that they have been meeting to discuss opioids and prescribing habits.
We have a caller from 817 area code. What's your name and where are you from?
This is Teresa Smith. I'm from Texas.
Hi, Teresa.
Hi, Teresa.
Hi. You were saying about Texas having that law that protects the practitioners. Mm-hmm. My daughter, a pain management doctor, has been cutting her medications in half. And my daughter had a stroke a year and a half ago. She's when she was 38. She has muscular dystrophy. She has had her stomach removed. She has had multiple surgeries, and right now her liver she's having problems with her liver stopping up right now, and it takes 4 different doctors to get her approved for one surgery, and they've got to have a general surgeon and a GI doctor in there to do her surgery because it's going to be so tricky, and she's in a lot of pain, and that's the first reason I took her into the general practitioner, who did some lab on her, found her liver was functions were too elevated, sent her to a GI doctor who sent her to a general surgeon, and roundabout they found out her liver muscle is spasming shut and won't let it drain. So they've been cutting her pain medicine back, and the doctor's been using legislation as a reason for it. He says, no, we can only give you 90 pain pills a month. That's 3 a day. Now, she has all these problems, and she's been on every 4 hours for probably about 10 years, because that's when she first started bleeding out in her stomach and everything. And he's using legislation. And I called today, and I told them about her liver and how much pain she's in. This has been going on for too long, and they're so hesitant about doing surgery till they get all their ducks in a row, because she has a bleeding disorder and an allergy. And so he's using that. And when they returned the call, they said, no, we don't treat that kind of pain, or that pain is not, narcotics will not help that pain. Well, now when she takes her pain medicine, it helps it.
Right.
And how can he use this law against her if we don't even have it? Is he...
Right. Well, I mean, according to my knowledge of Texas law, now I'm not a lawyer, so you'd have to, consult a lawyer for absolute facts on this, but the Texas Intractable Pain Patients Act isn't necessarily the strongest act ever made, meaning, okay, the intention was to protect physicians and create what's called a safe harbor for them to use their clinical judgment in treating pain patients, because at the time when this law was passed, I could be wrong, but I think the late 80s, let me check for sure, too many physicians were being punished or disciplined by the Texas Medical Board for prescribing controlled substances. And so the idea was to create a safe harbor so that if a physician could prove that they were practicing appropriately, as we used the reasonable physician test that we talked about earlier, which is what would a reasonably prudent physician in the same or similar circumstances do, as long as they could prove that even if the person was a habitual addict or somebody who was abusing, the physician wasn't supposed to be disciplined for treating that person's pain. Now, what you're seeing here, I think, is what we called earlier the chilling effect from the CDC guidelines. And it may be that your physician thinks that there's a law and is interpreting that way, so it may be a lack of understanding, or it may be that it's been presented to him through his malpractice coverage or through if his practice is owned by a group, he may have said, look, this is it. We're not prescribing any more than this. We're not. Now, of course, CVS has put the 90-tablet rule into effect. It's not a law. That's something they did on their own. So I think what you're seeing is a multi-layered, essentially, they're punting you guys somewhere else, because it may be that your daughter's conditions are such that, as I mentioned before, they have to evaluate their risk now in treating somebody with opioid medications. And many clinicians have decided it's just simply not worth the risk. And
that's what he told us.
Is that what he told you? Yeah.
That's what he told us.
You wouldn't
be
the first one.
He's worried about his practice. Now, he's been treating her for 10 years, and now all of a sudden, he's worried about his practice. But I do know that there are several doctors worried about their practice here. My pain management doctor has not cut my pain medicine yet. And my stepdaughter works for him, and she said as far as they're concerned they're not going to right now. But I got a letter from Blue Cross Blue Shield today. They assessed all my medications and sent me a copy of all my medications for the last 6 months and have decided that I'm at risk and that I should be going in and talking to my general practitioner and being sure that he's aware of all the medications I'm on and that I need to he needs to discuss what's going on with me. And in the mail, they sent me one of the, is it called Narcan, that you inject yourself with if you overdose?
Right, Narcan.
Narcan, yeah.
Narcan.
They sent, Blue Cross sent me one.
Well, that's
and,
one of the things that has
know,
been suggested to physicians to minimize their risk if they are opioid prescribing is to provide a concurrent prescription for Narcan, which actually stands for narcotics canceling, and essentially is a medication that can immediately result in the effects of an opioid overdose. It can reverse it.
Right.
A lot of the epidemic type, for people like first responders like EMTs and firemen and policemen and emergency rooms, that Narcan is they're hoping to put Narcan in every ambulance and every first responders because it can save the life of somebody who has taken too much. It seems so. You were subjected to a records review, and you've been flagged as somebody who could conceivably be at risk. So this would be they want you to go make sure that you're not using any concurrent substances that could conceivably cause you harm. And one thing I didn't mention earlier, but in the epidemic numbers, in addition to fentanyl, heroin, and fentanyl analogs being present in almost 90% of the overdose deaths, the other category is often what they call polypharmacy, where somebody has taken heroin and a benzodiazepine like Valium or Xanax and then drank a fifth of vodka. So we know that those combinations, matter of fact, there was one where sometimes where you would use a combination of benzodiazepine, an analgesic, and a muscle relaxant was called, the devil's triad, because if you took all three of those at once, you could conceivably suppress your respiration and overdose that way. And immediately, many pain doctors just stopped prescribing Soma or carisoprodol just because that it was known for that. So, physicians are always trying to balance the risk to themselves, the risks to patients, and also trying to treat pain. And what it seems like the CDC guidelines the effect has been, the choice is to it's less risky to the physician to let you or your daughter be in pain than it is for them to risk treating you. And this is a position that we don't feel like our physicians should be in. Like we are acting on behalf of physicians. We'd like to return the practice of medicine to their hands instead of a government committee. But I'm very sorry to hear what's happened. Yeah, no, that's a scary feeling for anybody.
As a potential prescription utilization and our coordination of care concerns. And now my doctors are going to have this because I go to a lot of specialists for my problems. And do I know if he knows every single drug I take? No, but when I go in, I take all my meds. And certainly my pain management doctor knows
to what's called, the prescription drug PMDP, where before you go in now, most pain management physicians or even your general physician will run a current list of what your pharmacy medications are. As per your contract with a pain management physician, you're only allowed to use one pharmacy. So then they can, produce. So everybody knows what you're taking. It seems a little heavy-handed, maybe what's happened to you with Blue Cross Blue Shield flagging you, because physicians can know what you are prescribed just by pulling your pharmacy records. Maybe they're trying to look out for you.
When I saw this entire list of all my meds and this letter telling me that I seem to have a problem when I'm barely being treated at all, in my opinion. I mean, I'm not on I'm on oxycodone, but I'm not on anything stronger than that. And I do take,
I'm sorry. Sorry, go ahead.
I do take Klonopin, and they did come in. My pain management came in and said that he would not treat anyone that takes both of them. He said that he did hear that there was a problem amongst that, and he's going in and talking to all his patients. The doctor came in, not anybody else, and talked to me about it. And I said, well, I don't know what to tell you because my psychiatrist gave that to me. And he said, oh, a psychiatrist gave it to you? No problem, he said. As long as you're being treated by a psychiatrist, I am home free and out of trouble. He said,
and you've been
no
on
problem,
it for a long
sign
time.
this.
You've been on that for a long time?
Since 1996.
Yeah.
Right. Well, there were several guidelines that the CDC produced, not just one, not just the 5090 that we've pretty much focused on today, but another one was to discontinue the use of an opioid with a concurrent benzodiazepine. And my guess would be that's what flagged you, is that you had a small dose opioid and a benzodiazepine, and that's just probably a computer that pulled that up and said, oops, this is in violation of the CDC guidelines, and we better make sure that whoever's prescribing these things knows what's going on, because that is considered to be a risk factor for overdoses, the use of a benzodiazepine and a narcotic. But recently, somewhere, I can't remember the CDC or someone, lightened up a little bit and said, if the benzodiazepine is providing effect and there's no respiratory depression, that it's acceptable clinically to go ahead and use too. Because for a while there, up till just this month, it was pretty much something that most patients were dropped off of. If you had one, you had to give up the other.
What I don't understand, though, is if they didn't ever have any problems with it in the past, and how do you know if they're having respiratory issues if they're in front of you living? What, you know what I mean? How did they prove that?
Well, right. That's another one. How do they prove any of these claims? The evidence base for the CDC guidelines has been admitted by the authors as poor, meaning that there aren't many studies that lead to any of the conclusions that they've drawn. The CDC said that they would be willing to look at the effect on the population and modify the guidelines, which we've seen absolutely no action on that front, in spite of the number of people who have been removed from their medications or forcefully tapered to a dose that doesn't help anymore, or who's even taken their lives because, as one patient said, he just felt as though he could see that he was going to be in a major car accident when his pain management said he'd be cut by 80%. He just thought, it's like watching a car wreck that I know is going to happen, except it's going to happen to me. And so it's been very harsh for patients who need analgesia for pain. And I'm glad that you were able to at least stay with the program that's worked for you for so long. But Janelle, you're right. As a patient's been stable since 1996, there's a pretty good chance that they're okay with that dose. But if you want to go with strict compliance to the CDC guidelines, you should not have a physician should not have a patient on both a benzodiazepine and an opioid narcotics.
The reason they put me on the Klonopin was because my husband committed suicide because of intractable pain that they would not treat.
My goodness.
Yeah, they flagged him as a drug seeker after he had major back surgery, and he fell out of an 18-wheeler after he'd gone back to work. He was a postman, and the truck had a broken handle on the door, and the guy had reported it, but Randy used it to pull himself up in the car, to the truck to sign some paperwork, and he fell and he landed on his back, and he had like 6 plates in his back. He had a major accident, and he was 39, and the doctor said, well, you're going to need some more surgery. And he'd been on pain medicine, and the doctor said that he wouldn't give him any pain medication anymore unless he did the surgery. And we left, and Randy said, I'm not going to do the surgery. And I said, well, you don't have to. It's up to you. I didn't understand what he meant. And he left that day, and the next person I saw was a coroner that came to my house to tell me that they had found Randy dead. He killed himself.
I'm so sorry to hear that. That is an unbearable grief. That is shocking to me that in our country we're putting our citizens in this position. I almost don't know how to respond, but just to say, bless you. You have been through so much. And anything we can do to help you and every other patient who might be in this situation, we are doing. Not just our group, but so many groups out there are fighting for pain patients' rights to adequate management. So maybe you can connect with Janelle after the show, and we can exchange emails, and maybe you can join us if you feel like it, if you feel up to it.
Okay.
That's a very compelling story. And maybe it's time to get you in front of some legislators and policymakers and start telling his story, because you're not alone. There are many widows and widowers and parents who have lost their children due to forced removal of adequate analgesia, and especially in patients who have been stable and have never done anything wrong.
I know.
It seems a pretty harsh consequence, and I'm so sorry that this happened to you.
Thank you very much.
Well, Teresa, thank you so much for calling in. Did you have any other comments or questions?
Nope, that's it. I was just worried about Blue Cross.
Well, let's get together, Teresa, and we'll let's use what happened to you for the sake of the cause.
Perfect. Okay, thank you. Great.
Thank
for
you.
calling. Bye-bye.
I'm trying to look through here because people are talking about something on YouTube Live that I wanted to say out loud on here. Cigna. What is Cigna? Oh, they're giving financial incentives to the manufacturer. Did you hear that?
I'm not aware of that. For what? Incentives for what?
To not prescribe opioids. Sorry, to the doctor.
So the insurance company is providing financial incentives for practitioners not to prescribe opioids.
Yes.
Is that correct?
Yes.
I haven't read about that yet, but I would certainly be interested in knowing more about that if whoever has commented on it could provide more information.
It's Stacey Fields. So,
okay.
or it's financial incentive to the drug maker to the drug maker to encourage not to write. No, it can't be drug maker. It has to be the doctor. Okay, yeah. Or to keep them at low dosage. So, yeah, keep low dosages.
Right.
Sorry. And that too.
Right. I mean, what happens is it's been on New Life, and we're seeing it now. As a matter of fact, some news article was now talking about suing hospitals for making patients addicted when they had pain relief during surgery. It's sort of like, well, would you prefer to have your surgery without pain relief? Because we can do that for you, if that's a concern. But, it's gotten a little extreme. I've even heard of states considering passing laws to allow veterinarians access to the pet owner's prescription drug management profile at the pharmacy before they give their pet pain medication to make sure that, that's not another area of diversion. It seems to just have snowballed into an avalanche, and this has to be reined back in. Some people have called it opioid phobia, and I can see why.
Yeah, it is. So I have a question about all the statistics constantly used. When I try to match them up, they're inconsistent, such as the amount of overdoses in 2016 due to opioids. Why is this, and what's going on?
Oh, that's another excellent question that our statistics are completely unreliable for so many reasons. One of the first ones that I find the most extreme is the fact that there's a difference between a medical examiner and a coroner. And different cities and counties, some employ medical examiners who are actually certified medical doctors, who went to medical school. But to be a coroner, in many countries, all you need is a voter's ID card, and you are eligible to become a coroner in that county. So the level of training is a huge gap between medical examiners and coroners in terms of reporting the cause of death. A second problem is that there's no standard toxicology panel. Even if you thought it was an overdose opioid death, certain toxicology panels can cost $13,000 to $16,000 per patient to try to determine the exact cause of death. And in small towns with small budgets, those are not the kind of tests that usually a coroner's office has the budget to run. So many of these things are just guesses. And a third problem with our statistics is that, remember how I mentioned polypharmacy overdoses, where there's a benzodiazepine, a muscle relaxant, and a narcotic on board? That death will be reported in all three categories. That one person's death could be counted and looked at statistically as 3 deaths. And one of the CDC guidelines, CDC studies, right underneath the graphs about deaths, it said, this data is unreliable due to inconsistent reporting methods and the practice of counting the death numerous times due to polypharmacy overdose. So we don't even have any real idea what the numbers are, but I do see, like you, it changes depending on who's writing the story that day. But I will tell you that if the CDC reported that 33,000 people died of overdoses, and they didn't differentiate between people with legitimate prescriptions and people who died from illicit or illegal use, 88,000 people in that same study died of alcohol poisoning, and 440,000 were victims of preventable medical error. So you have to wonder where the epidemic really is. We think that if we were really about saving lives, we might focus on preventable medical error. That would be a good place to start. And another issue with this whole campaign is that, if you'll notice, the focus is only on opioids, but we're not treating people who abuse other drugs like cocaine, meth, ecstasy, MDMA. These are not people that we're concerned about. So you kind of have to wonder if this is really about saving lives, or if this is more about access to funding that was created during the Affordable Care Act that people have learned how to profit from. I think I read that 10,000 new rehabilitation facilities opened last year to take advantage of basically free government money. So this doesn't seem to be the most well thought out set of guidelines ever. And we really do have hopes that the Health and Human Services Task Force can right some wrongs. But we do have to get our faces in front of our legislators to let them know how bad this problem is.
Right. Is there anything else that you wanted to add before we get going here that I might have not covered tonight, or that we missed?
I think that was a very thorough coverage of many of the issues. So I just want to commend you for your dedication to this cause. Those of us who are familiar with your work have followed you through your journey to the Senate, and the work that you've done in educating yourself, and your dedication to helping all of us is unparalleled. And I think we all just want to thank you for continuing, even when you're tired or you're beat or you're in pain. You press on to help and care for those who need advocacy. So I think on behalf of the entire country, we would like to thank you, Janelle, for the work that you've done.
Thank you. I appreciate that. Could you give us one more time the name of your Facebook group and your website? I know Rose told me the website. She's on here. Let me find that quickly. Would you like to talk about your website one more time, or any information quickly?
Yeah, well, the name of our group is the Alliance for the Treatment of Intractable Pain. We go by ATIP. And you can find us on Facebook at ATIP USA. And if you would like to say hello to us, just go ahead and leave a comment. You can send a direct message if you'd like to speak with any of the directors of the group, and we can start providing you with information. We have tasks that we're taking care of as a group, like certain petitions in front of the FDA to limit opioids. We have some action items that everyone can start doing and helping us do. So there's work to be done, and you can start right there on our Facebook page. So, again, ATIP USA on Facebook.
Wonderful. Thank you so much. Well, I appreciate you coming on tonight and sharing all this information. And we need to have you back, because I know there's so much that I think we really need to go into some of the stuff in detail, because if we don't, we're never going to learn about it. So until this could change, I would hope you would come back very soon.
Yes, I think this was a very thorough overview of many of the issues that are intertwined. But yes, we could start pulling apart each piece of that rope and follow it down and look at kind of the roots of where we are and how we got here. That would help everybody communicate more effectively.
Awesome.
So, yes, I'd love to come back.
Awesome. Wonderful. We will have you back then. I hope you have a great night. And, again, thank you just for coming on and sharing everything. All the work that you do. You do such great work.
Thank you, Janelle. But right back at you, girl. And thank you for having us. And, please, we look forward to meeting as many as we can on Facebook and also through Janelle's work and advocacy on her Conspiracy Against Wellness. So good night, Janelle, and thank you so much.
Good night. Well, everyone, Con Nation, thank you so much for joining in YouTube Live. You guys were awesome. I loved all your comments and questions. I apologize. I'm really stuffed up right now. But I hope you have a great night, a great weekend, and we'll be back here on Tuesday at 8, 7 Central.
Listening to Conspiracies Against Wellness with Janelle Elgaway. Join us next week to get in on the conversation. The opinions expressed on this program are those of the host and callers, and not necessarily those of EXG, LLC, its employees, or sponsors. I'm David Schiff.
The Cause Show with Janelle Elgaway is copyright 2017 by EXG LLC. All rights reserved.